So the lower cervical spine, the involvement would be different in a skeletally immature versus a mature patient. So less than 10 years would be skeletally immature, more than 10 is skeletally mature. So generally it is seen that in the skeletally immature cases, there is a diffuse involvement. However, in mature patients, there is a localized involvement. In immature patients, you're going to witness a large abscess formation, and in mature patients, there would be very less pus. Because of the large abscess formation, there is a tracheal compression, and in mature patients, cord compression is rather seen in 15 to 45% of the cases. Kyphotic deformity is severe in immature, not prominent in mature. So I'm repeating. In the immature patient, the type of disease that you will see in lower cervical spine is something that is going to have a diffuse involvement. The abscess would be large. There would be significant tracheal compression, and the kyphotic deformity is also severe. As against this, when we talk about mature patients beyond 10 years of age, they have a localized involvement. They have less pus. Cord compression is seen in 15 to 45% of the cases, and deformity is not that prominent. So this is a difference between an immature and a mature patient. In young children, generally it is seen that the patients would have night cries. They also would have inspiratory stridor. So whenever they breathe, they are going to make that characteristic stridor sound. There would also be transient attacks of cyanosis, and cold abscesses can occur in the retropharyngeal space, anterior triangle or posterior triangle of the neck. So what you're seeing over here is a cold abscess which may occur in the retropharyngeal space, either in the anterior or the posterior triangle of the neck. So that is what happens in young children. Thoracolumbar. Most common symptom of thoracolumbar tuberculosis is gradual onset localized pain. In fact, most of the cases that are neglected are these ones, because these patients think that this low grade lingering pain is a mechanical pain and not a pain secondary to some massive disease pathology. Constitutional symptoms like fever, malaise, anorexia, night sweats, and weight loss are something that you would see. Neurological involvement is high, 10 to 46% of the cases, because the cord to canal ratio is the least. Weakness in limbs and loss of bladder and bowel control is something that is seen. So the most common symptom would be gradual onset localized pain. Constitutional symptoms would be seen like fever, malaise, anorexia, night sweats, weight loss. But these are not the symptoms that you would see in the initial phase of the disease. They would be seen, to my understanding, in a bit advanced stage of the disease. Neurological involvement is high. 10 to 46% of the cases have deficit because of cord to canal ratio is the least. Weakness in the limbs would be seen with loss of bladder and bowel control. So neurological involvement becomes high because if this is the canal, 80% of that would be occupied by the spinal cord, and this causes the weakness in the limbs. Cold abscesses can be seen in the anterior chest wall. They may be seen in the lower abdominal wall, in the thigh, in the Petit's triangle, in the ischiorectal fossa. Now, cold abscesses are the ones that generally go along the pathway of the nerve. So, in the areas where the nerve involvement is the same or the nerve supply is the same, those are the areas that are tracked via these cold abscesses. So these cold abscesses in the lower abdominal wall may travel via the ilioinguinal nerve, iliohypogastric nerve, or the intercostal nerves. In the thigh, they may travel via the psoas muscle. In the Petit's triangle, it comes along the flat muscles of the abdomen, and in the ischiorectal fossa, along the pudendal nerve. So these nerves and understanding these muscles is important rather than remembering this, because this is asked you in the MCQ and also in the Viva. So most common is along the nerve, but it may also happen along the muscle. Lower abdominal wall may be via ilioinguinal, iliohypogastric, intercostal nerves. Ischiorectal fossa is via pudendal nerve. In the thigh is along the psoas muscles, and in the Petit's triangle along the flat muscles of the abdomen. Now, this is how cold abscesses look like. These are big abscesses that you see over here, and these cold abscesses just have pressure or the swelling. They don't cause much of pain, I would say, but the swelling is there, and sometimes this causes low grade lingering causes once it increases in size, not low grade, but lingering cold abscess, which keeps on increasing in size, may cause sinus development, which may get super addedly secondarily infected via some bacterial organism. And there is a lot of literature on this, wherein it started off with a cold abscess, was not treated on time, and then it caused and it went to becoming a secondarily infected via some bacteria. Most common staph. Lumbosacral region, so there is a back pain with stiffness, limited range of motion. So these patients generally again have back pain. They would complain of some stiffness and limited range of motion because because of the infection, the bending becomes restricted. Clinically, you may see a loss of lordosis or hypolordosis, and sometimes in progressed cases, you may see kyphosis, which is a deformity. Average kyphotic angle per each vertebral body is 4.9 degrees in lumbar region, 27 to 30 degrees in thoracolumbar region. So this is how the kyphotic angle per vertebral body loss is incurred. Flexion contraction of the hip is due to the large psoas abscess. Weakness is also seen in the lower limbs. So whenever it involves a psoas abscess, there is a flexion contracture of the hip. Kyphosis, tuberculosis preferentially affects the anterior elements of the vertebral column in more than 90% of the patients. So, in more than 90% of the cases, it would affect the anterior element of the vertebral column. Appearance depending on the number of vertebrae involved. If there is only one vertebrae involved, that is a knuckle. If there are two vertebrae involved, that is a gibbous. If more than three vertebrae are involved, that is a rounded kyphosis. So one vertebrae, knuckle, two is a gibbous, and more than three is a rounded kyphosis. So this is how, depending on the number of vertebrae involved, the patient may have a knuckle, gibbous, or a rounded kyphosis. Also, when we come to calculation of the deformity in the patients, Rajasekharan et al. Gave this formula y is equal to a plus bx. Y is the final angle. A and B are constants, which is 5.5 and 30.5, and x is the initial loss of vertebral height in the thoracic and thoracolumbar spine. So, depending on that, you would be able to predict what would be the final amount of deformity. Now, y is equal to a plus bx is an important formula because this is multiple times asked in the MCQ. They ask which is a correct formula. They ask what are the constants. So these are the different ways in which this particular question is asked in the MCQ, in your entrance, and also sometimes in the exit exams. Kyphosis, patient treated with chemotherapy alone. Chemotherapy in the form of anti-tubercular therapy alone have an increase of 15 degrees in deformity, and 3 to 5% of the patient develop kyphosis, which is greater than 60 degrees. So the patients, in spite of being treated, they would have an average increase of 15 degrees in deformity, and 3 to 5% of the cases would develop kyphosis, which is more than 60 degrees. A severe kyphosis can lead to immense cosmetic and psychological disturbance in growing children, and it can also lead to costopelvic impingement, secondary cardiorespiratory problems, and late onset paraplegia. So, whenever the kyphosis is severe, that would obviously lead to some cosmetic issues. It can also cause pain. Why the pain would be there? Because of costopelvic impingement. And this pain of costopelvic impingement is severe. There are also secondary cardiorespiratory problems and late onset paraplegia. Depending on the extent of the initial vertebral loss, three types of collapse and healing in the anterior column are noted. So these three types are again important because they are asked in the exam. So there are three types of restabilization: type A, B, and C. So what do we mean by restabilization? Restabilization is basically once the infection happens, the destruction happens, how much would be the final deformity? So this restabilization A, B, and C would be dependent on where the integrity of the anterior column, the amount of vertebral body loss, and the facet joints. So type A basically is when the anterior column contact is wide. So as you're seeing, the anterior column over here is very much wide in contact. And over here, the anterior column is only in point contact. So this is the white column contact of the anterior column, and this is the point contact. And type C is when there is a 90-degree sagittal rotation of the superior vertebrae. So this is type C. In type A, generally the vertebral body loss is less than 3/4 of one vertebral body. When 3/4 to 1.5 vertebral body loss is there, that is type B. More than 1.5 vertebral body loss is type C. So whenever we have the facet joints which are intact, that is type A. Whenever we have facet joints that are subluxated or dislocated, that is type B. Type C is when there is a dislocation of two or more facet joints. So my friends, white contact is A with a less than 0.75 or 3/4 of the vertebral body loss with intact facet joints. Type B is point contact of the anterior column, as you see in the second image over here. Along with that, the loss of vertebral body would be between 3/4 of a body to 1.5 vertebral bodies, and that would be associated with subluxation or single level dislocation of the facet. But when there is a 90-degree sagittal rotation of the superior vertebrae with more than 1.5 vertebral body loss, with dislocation of two or more facet joints, that is type C. Final deformity is spontaneous improvement is seen if the increase is less than 10 degrees in type A. Final deformity would be less than 60 degrees in type B, and it would be more than 100 degrees in type C. So this is how the final deformity can be understood via the type of restabilization, be it A, B, or C. Type A, there would be a spontaneous improvement or increase would be less than 10 degrees. Type 2 is less than 60 degrees increase in kyphosis, and type C is when the kyphosis can go beyond 100 degrees.